Hello everyone and welcome to another rapid ECG session with Pekga, Practical EKG Academy. Today we're going to be taking a look at this 12 lead, very fast rhythm. However, as usual, we are going to be breaking it down and we're going to be starting off with a single channel view. So let's take a look at this. Let's say somebody hands you this strip and you got to make sense of it. As always, the only thing you can really reliably pull off of a single channel is rate and rhythm. Rate and rhythm, right? And when somebody mentions rate, your immediate response should be the rate of what, right? Because you couldn't have atrial, ventricular rates. And your rhythm, it gets tricky. As you, for some of you that have seen several of these Pekga videos, you know that the rhythm can be a tricky topic to cover, to pull off of a single channel. So let's get into it. As far as the rate goes, I'm going to be looking for a QRS that lands on one of these right here, that lands on one of these darker lines. Now, using the 300 method, right, this would be your 300 mark, this would be 150, so this is somewhere between 150 and 300, looks like 200. This is a little imprecise, so I'm going to be narrowing it down and I'm going to be measuring these small boxes using the 1500 method. Now, 1500 divided by 5 plus 3 here, 8 boxes, will give you a rate of 187.5. Now this 0.5 nobody's really going to care about. You can call it 188, 187. You can call it 190. I don't think anybody would care. It's so fast. The other thing off of here is the rate is regular. So your ventricular rate is regular. The QRS complex is narrow. It's roughly, what is this, two and a half boxes wide, so that's 100 milliseconds maximum. T wave is looking nice. It's present after every QRS. I'm not seeing anything going on in the ST wave. However, the P waves, right, so this is your QRS complex, this is your T wave, but where's your P wave? The P wave is missing. It's either hidden in there or it's missing. So what do we have here? We have a narrow complex, right? So it's less than 120 milliseconds. So we're looking at narrow complex tachycardia. It appears to be supraventricular, right? Most of the time your narrow complex is going to be supraventricular. Not always, right? So we have SVT here at 187.5 beats per minute. Now, when we expand this to the 12 lead segment, here, we can gather a little bit more information. Let's see here. I'm looking for the P waves. I'm trying to find these P waves if they're visible anywhere. They are not. So I'm going to go back to my analytics, right? The first thing that really jumps out at you is the rate. The rate is so fast. It's it's really kind of plastering me like this is fast, react right away. However, I'm going to take a look at the axis. That's going to tell me maybe something. So the axis, it's upright in V1, it's upright in V2, it's downright in lead 3. This is probably normal. Oh, look at this. This is an isoelectric or equiphasic what do you call it, axis going on here. So I'm going to take a look at my AVF. AVF is down here. The axis perpendicular to it is axis in lead 1. If we take a look at the axis in lead 1, it's completely positive. Completely positive. So my axis is probably going to be somewhere around 0, maybe a little bit down. So this is normal, right? I'm not having any sort of axis deviation. Moving on further, AVR is inverted, so that's normal. AVL appears to be as it should, so that's good. Switching over to my transverse plane, So we're going from our coronal or frontal view to our precordial leads, and we're moving over to the transverse plane. I'm looking at the R wave progression, and here the R wave, if it's existent at all, and it appears to be that it is, it's small, it immediately shifts from predominantly negative to a predominantly positive. So your R wave progression is happening somewhere here. That's early. So something is going on here. So far, what do we have here? We have narrow complex, right? We have SVT. Now in SVT, I try to find what do you call it, P waves. They should be appearing either before or after the QRS complex. It's very, very difficult on this ECG. I mean, you know, this could be something. This could be something. Is it? It's not consistent if it is. What you do with SVT, the first thing that I do is I will go to lead V1, and what I'm looking for is R prime. So I'm looking for R prime. So you would have your first R wave, you know, it would be labeled R. Your second R wave, if it's present, would be labeled R prime. So here what it looks like, I mean, this is really horrible to look at, but you will be in this situation, so you gotta learn how to deal with this. To me, what it looks like, especially right here, is that we do have an R wave, it goes down into an S wave, and then look at this, we have a little bit of a baseline here, but there's something happening above the baseline, and I would call that an R prime. And this is typically associated with atrial depolarization that's happening after the fact, which is a telltale sign of nodal SVT, right? So in this case, this would be enough to make a determination that this is AV and RT. Now, this is an extremely complicated subject, and I will not be going into any depth here when it comes to AV and RT in this video. However, in the expanded video, with the link down below in the description, you can check it out, and we'll be going into SVT in a little bit more detail. Now, let me show you what happened. So this lady was seen, and when the attending physician saw this fast heart rate, the first response was to try a vagal maneuver, right? And once the vagal maneuver, now there's several different ways you can do this vagal maneuver. Somebody can bear down. You could splash some cold water in somebody's face. Maybe not splash, but have them, put their face in a bowl of cold water, wakes up a reflex and slows down the heart rate, just as you would if you were to go diving. So what happened here, they had this lady blow on a syringe, right? Of course, there's no needle on that syringe. What happens is the person blows on the syringe, and it forces the vagal nerve, your cranial nerve number 10, right, to kind of go into hyperdrive, if you will, and it slows down the rate. And this is what happened. So they successfully converted this lady from SVT into, now let's take a look at this rhythm. What do we have here? Rate and rhythm, right? 300, 150, 175. This is roughly between 175. So this rate here is like, whoopsie daisy. Okay, this rate here is roughly, oh, why? Pardon me, guys. This rate here is roughly 85, maybe 90 beats per minute, which is, they've effectively cut the rate down in half. However, the P waves now are visible. So see, we can see our P waves here. The QRS is still narrow. It's roughly the same size. The T waves are present. Here we can take a look at our QT interval, right? We get kind of a half line. We don't have any QT issues. I would not say so. However, I'm going to go back to basics, right? So I'm not happy with the fact that we have a normal rhythm now, if you will. I'm going to go back to basics and double check everything. So I'm looking at the P wave. I want to see if this is truly a sinoatrial rhythm. So P wave is upright in lead 1 and lead 2. It's negative in AVR. It appears to be upright. It's kind of visible in AVF. So yeah, I would say that this is normal sinus rhythm. However, when we take a look at the axis, look at this. It's upright in lead 1. It's down in lead 2. It's down in lead 3. So this is left anterior fascicular block or hemiblock, right? So when this lady converted, which is not present here, right? Here the axis was normal. However, look at this here. So here we have left anterior fascicular block in normal sinus rhythm. The QRS is still narrow. What else can we pull off of here? Let's take a look at the R wave progression. V1 is looking pretty much the same, which in itself kind of raises another question. Is this really AV-nRT? And that is a good question to ask. However, just looking at R wave progression, the R wave is barely existent here, right, in lead V1, and then immediately jumps to a predominantly positive wave in V2. So R wave progression is still early. So we have early R wave progression. There's a few other things on here that I'm not discussing that I will be discussing in the expanded video, so you can check that out in the description below, where I will be going into different SVT possibilities here and why that is and why I would suspect that. However, I will mention this. It is not uncommon for somebody that converts from SVT to show left anterior fascicular block. This can be a functional reason. So at a higher rate, the left anterior fascicle is not completely, and left anterior, for those of you who are not familiar, left anterior fascicle, so I'm not sure if I have a good graphic of it, but your left bundle bifurcates into the anterior fascicle, into the posterior fascicle. And when you have a partial block, right, one of these fascicles would be blocked off either partially or fully, and that will cause axis deviation on your ECG. So that's what's going on here. However, at a higher rate, this fascicle is able to function properly, quote unquote, right? It's able to function properly. Again, I'll be going into this a little bit further in the expanded video, in the deep dive video. So feel free to check that out. In the meantime, thank you for joining us on this. And yeah, if you were handing over this sheet of paper, so if you were handing this over to somebody or putting it in your report, right here you have SVT. The fact that you suspect AV-nRT, you can jot that down in your notes, but it is not conclusive. So write down SVT or NCT. And of course, the rate, 187 beats per minute. Convert it into normal sinus rhythm with left anterior fascicular block. And the rate is 85, 90 beats per minute. Your machine should tell you that, right? I didn't really go into the PR interval. It appeared to be just fine over here. However, when we take a closer look at it and some other leads, which we will be doing in the deep dive video, there's a couple other things that show up. Anyhow, thank you for joining us on this rapid ECG interpretation. We will see you on the next one.